features. Management of beta thalassemia, clinical features. Progressive pallor requiring early transfusion. Progressive pallor requiring early transfusion. Lethargy and effort intolerance. Lethargy and effort intolerance. Failure through thrive and growth retardation. Psychological depression. Recurrent infections, problems in movement and abdominal discomfort because of massive splenomegaly. Sometimes patients presents with features of respiratory distress from anemic heart failure, gum bleeding and pathological fractures. Features of iron deposition. Diabetes mellitus, CLD, cardiomyopathies, arrhythmias, heart failure. Cardiomyopathies, arrhythmias, and heart failure. Cardiomyopathies, arrhythmias, and heart failure. Endocrinopathies, hypothyroidism, hypogonadism, delayed puberty, delayed puberty, epilepsy, and neuropsychiatric problem. Physical examination, pallor, jaundice, changes in facial profile like frontal and parietal blossing, depressed nasal breeze, prominence, zygoma, and maxillary prominence. Mal-aligned jaw and teeth, complex zone, greenish brown, growth failure, massive splenomegaly. Laboratory investigations, blood and radio imaging. Blood, reduced hemoglobin, microcytic hypochromic anemia, anisocytosis, poikilocytosis, target cells. Anisocytosis, poikilocytosis, and target cell. Increased reticulocyte count, serum iron profile, increased iron ferritin percent saturation, and only decreased total iron binding capacity. Serum unconjugated bilirubin may be raised. Hemoglobin electrophoresis, markedly reduced hemoglobin A and raised hemoglobin F and hemoglobin A2 confirmatory. Markedly reduced hemoglobin A, raised hemoglobin F, raised hemoglobin F, and hemoglobin A2. Radio imaging, X-ray skull, increased diploic space, hair on end appearance. X-ray of long bone shows Lassie increased trabecular mosaic pattern and osteopenia. Lassie increased trabecular mosaic pattern and osteopenia. Increased trabecular mosaic pattern and osteopenia. Mosaic pattern and osteopenia. Trabecular mosaic pattern and osteopenia. Treatment of thalassemia. Treatment of thalassemia: blood transfusion, target hemoglobin, pre-transfusion hemoglobin, post-transfusion hemoglobin, and mean hemoglobin. Treatment of hemoglobin: blood transfusion, iron chelation, hydroxyurea, Number 4, hematopoietic stem cell transplantation, gene approach. Number 5, gene approach. Number 6, diet and nutrition. Blood transfusion, target hemoglobin. Blood transfusion, target hemoglobin. Pre-transfusion 9 to 10.5 gram per deciliter. Post transfusion around 15 gram per deciliter. Mean 12.5 gram per deciliter. Iron chelation indication and drug used. Iron chelation indication: usually after 10 to 20 transfusion, when serum ferritin is greater than 1000 nanogram per milli, when liver iron concentration greater than 5000 microgram per gram of dry weight. Drug used: desferoxamine, deferasirox, and deferipun. Desferoxamine. Drug is used: desferoxamine, deferasirox, and deferipun. Hydroxyurea increased hemoglobin F synthesis. Hematopoietic stem cell transplantation, gene approach. Diet and nutrition: the child can eat and drink normally and better to avoid red meat, liver. Drink like tea, coffee decrease iron absorption, hence advised to drink just after meal. Vitamin C increase iron excretion. Give micronutrients, example vitamin D, C, and zinc. Then vitamin E. Now counseling of the parents of a thalassemic child regarding future pregnancy. Counseling: they should be informed about the nature of disease. It is possible to identify a fetus with homozygous beta thalassemia by obtaining chorionic villus material or for DNA analysis sufficiently early in pregnancy to allow termination. It is possible to identify a fetus with It is possible to identify fetus with homozygous beta thalassemia by obtaining chorionic villus material for DNA analysis. Possible to identify fetus with homozygous beta thalassemia. thalassemia by, by obtaining chorionic villus material. Chorionic villus material for DNA analysis. For DNA analysis sufficiently early in pregnancy to allow termination. Now, complications of repeated blood transfusion. Complications of repeated blood transfusion. Transfusion reactions: febrile, allergic, hemolytic, and anaphylactic. Febrile, allergic, hemolytic, and anaphylactic. Transfusion reaction: febrile, allergic, hemolytic, and anaphylactic. Transmission of diseases such as hepatitis B and C, HIV, malaria. Transmission of disease such as hepatitis B and C, HIV, and malaria. Iron overload that may lead to hemochromatosis. Other complications: RBC allosensitization, HLA allosensitization, and graft versus host disease. HLA allosensitization and graft versus host disease. Hepatosplenomegaly. 5 differential diagnosis of hepatosplenomegaly. Differential diagnosis of hepatosplenomegaly. Congenital hemolytic anemia, then Kala-Azar, lymphoma, malaria, and leukemia. Investigations planned with expected findings. ESR raised in Kala-Azar, lymphoma, and leukemia. ESR raised in Kala-Azar, lymphoma, leukemia. Kala-Azar, lymphoma, and leukemia. Then hemoglobin decreased in congenital hemolytic anemia, Kala-Azar, and malaria. ESR increased. Then hemoglobin decreased in congenital hemolytic anemia, Kala-Azar, and malaria. Total count and differential count of WBC. Kala-Azar, leukopenia with relative lymphocytosis. Leukemia, increased leukocyte and lymphocyte count. WBC, Kala-Azar, leukopenia. Decreased and increased in leukemia. Peripheral blood count, PBF, peripheral blood count. Target cell, fragmented cell found in congenital hemolytic anemia. Target cell and fragment cell. Congenital hemolytic. Fractures of pancytopenia. Features of pancytopenia in Kala-Azar. Atypical cell or blast cell in lymphoma. ICT for Kala-Azar and malaria. ICT ICT for Kala-Azar and malaria. Bone marrow examination and hemoglobin electrophoresis. Bone marrow examination and hemoglobin electrophoresis. Beta thalassemia. Beta thalassemia, progressive pallor. Clinical features: progressive pallor requiring early transfusion, lethargy and effort intolerance, failure to thrive and growth retardation, psychological depression, recurrent infection, problem in movement and abdominal discomfort because of massive splenomegaly. Sometimes patients presents with features of complications: respiratory distress from anemic heart failure, then gum bleeding and pathological fractures. Respiratory distress, gum bleeding and pathological fractures. Features of iron deposition. Diabetes mellitus, chronic liver disease, cardiomyopathies, arrhythmias and heart failure, endocrinopathies, hypothyroidism, hypogonadism, delayed puberty, epilepsy and neuropsychiatric problem. Now physical examination shows pallor, jaundice, changes in facial profile like frontal and parietal bulging, depressed nasal bridge, prominent zygoma, maxillary prominence, malaligned jaw and teeth. Complexion greenish brown, growth failure, massive splenomegaly. Laboratory investigations: blood, reduced hemoglobin, microcytic hypochromic anemia, anisocytosis, poikilocytosis, target cell, and target cell, microcytic hypochromic anemia, anisocytosis, poikilocytosis and target cell, increased reticulocyte count, serum iron profile, increased iron, ferritin and percent saturation, only total iron binding capacity decreased. Serum unconjugated bilirubin may be raised. Hemoglobin electrophoresis, markedly reduced hemoglobin A, raised hemoglobin F and hemoglobin A2. Radiological findings: X-ray skull, increased diploic space, hair on end appearance. X-ray of the long bone shows lacy, increased trabecular, mosaic pattern and osteopenia. Treatment of thalassemia. Blood transfusion, target hemoglobin, pre-transfusion 9 to 10.5, post-transfusion hemoglobin around 15 gram per deciliter, hemoglobin electrophoresis 12.5 gram per deciliter. Iron chelation, indications usually 10 to 20 transfusion when serum creatinine is 1000 nanogram per milli, when liver iron concentration greater than 55,000 microgram per gram of dry weight. Drugs use: desferoxamine, deferasirox and deferipone. Hydroxyurea, increase hemoglobin F synthesis. Hematopoietic stem cell transplantation, gene approach. Diet and nutrition: the child can eat and drink normally and better to avoid red meat, liver. Drink like tea, coffee decreases iron absorption, hence advised to drink just after meal. Vitamin C increases iron excretion. Give micronutrient, vitamin D, C and zinc. Vitamin E. Counseling of the patient of a thalassemic child regarding regarding future pregnancy. They should be informed about the nature of disease. They should be informed about the nature of disease. It is possible to identify fetus with homozygous beta thalassemia by obtaining chorionic villus material for DNA analysis sufficiently early in pregnancy to allow termination. Now, complications of repeated blood transfusion. Transfusion reaction such as febrile, allergic, hemolytic and anaphylactic. Transmission of diseases such as hepatitis B and C, HIV and malaria. Iron overload that may lead to hemochromatosis. Other complications: RBC allosensitization, ACL allosensitization, and graft versus host disease. 5 common differential diagnosis of hepatosplenomegaly: congenital hemolytic anemia, kala jar, lymphoma, malaria, and leukemia. Investigation plan with the expected findings: complete blood count, we get ESR, hemoglobin, and WBC count. ESR raised in ESR raised in kala jar, lymphoma, leukemia. Hemoglobin decreased in congenital hemolytic anemia, kala jar and malaria. Total count and differential count of WBC: decrease in kala jar, leukopenia and relative lymphocytosis. Decrease in kala jar and increased in leukemia. WBC count increase in leukemia. Peripheral blood count. In congenital hemolytic anemia, we count target cell and fragmented cell. In kala jar we get pancytopenia, and lymphoma we get blast cell or atypical cell. ICT is done for kala jar and malaria, bone marrow examination, and hemoglobin electrophoresis.